Thank you so much, Nishant. It is a pleasure to be here, even though it is 5 o'clock in the morning. I think my fellows, Christian and Nashwa, are still getting their beauty sleep. Good for them. They'll watch it on YouTube. So it is better than getting on a plane and flying across the East Coast to give a lecture at what ends up being 5 o'clock. So we'll go from here. See if I can advance. There we go. Breeze past my disclosures here. I don't think they have any relevance to what we're going to talk about today. So goals for this talk, mapping and ablation of PVCs, really common procedure that you're going to do a lot, really regardless of where you end up practicing. Frequent PVCs are not a rare occurrence. So we'll talk about patient selection for ablation, how to maximize that, pre-procedural evaluation, how much testing a patient needs before they come to the EP lab, a little bit about case setup, and then mapping strategies and principles, as well as ablation strategies, and then some final words of advice. I did want to sort of give a shout out to this series in general, and Nishant certainly in particular, who's arranged this during our unprecedented, challenging times. There are a lot of overlapping lectures that certainly stand on their own as well as this, but I'm not going to get into as much detail with papillary muscle ventricular arrhythmias, for instance, which ends up being a common PVC ablation strategy. Just this week, Jason Bradfield went over mapping and ablation of outflow tract VT, and by necessity, we're going to have lots of overlap today, but that's fine. I also did not end up including a ton of ICE images because we now have a really beautiful repository from Mansoor Rizmini and also from Chicago. And you have talks coming up for vesicular VT. A certainly very interesting aspect of PVC ablation is PVC triggered ventricular fibrillation. But I didn't feel like I needed to compete with Dr. Belhassen, who did go over that earlier in the series here. So, you know, you're coming into clinic, maybe it's just telemedicine clinic these days, and the reason for referral is PVC. So how do these patients generally present? So palpitations, I would say, is still one of the most common. We have a very, very active heart failure group, like a lot of the bigger academic centers. And so cardiomyopathy with the incidental finding of PVCs is very common. Pseudobradycardia, I still get referrals for folks for pacemakers, and it turns out that their underlying issue is frequent PVCs, and we'll go through that, as well as just the incidental finding of frequent PVCs. Folks who have CRT devices with heart failure, low BIV pacing percentage remains something that we see quite a bit. How frequent are PVCs? I get asked this question a lot. Patients always want to normalize their disease process, and PVCs turn out to be really quite frequent when you do large scale studies. There have been studies within the VA, studies of medical students over the years who've worn Holters. And it's about 1 to 4% of the population that have some degree of PVCs at any given time. 70% of folks greater than 75 years old would have greater than about 0.2% PVCs on a 24-hour Holter. So again, relatively low burden. The incidence of, coexistence of cardiovascular disease with PVCs sort of has an inflection point at that 100 to 200 PVCs in a 24-hour period. So not that many PVCs in a particular patient can put them at risk of having some sort of cardiomyopathy, not necessarily causal, but at risk of having that association. So how many PVCs does it require to have a cardiomyopathy? And this is actually a more difficult question to really answer. And it's something that we're called upon frequently to prognosticate for patients. This is the ERIC study, which is the atherosclerotic research study that enrolled 13,000 patients, 13,500 patients, and just followed them longitudinally. And they looked really extensive imaging and EKG and echo. They looked at whether or not patients had PVCs, and the presence of PVCs over time nearly doubled your risk of development of congestive heart failure. And this is very long-term follow-up, over 15 years. Blue line here being no PVCs, and red line being really any PVCs on Holter monitor. So we do know that there is an uptick. The question is, if you have an asymptomatic patient sitting in front of you with known frequent PVCs, will they develop cardiomyopathy? And the question is also why. So we know that, say, rapid atrial fibrillation can cause it, but it is a little bit potentially surprising that PVCs can cause weak heart muscle. And the mechanisms are thought to be multifactorial. So one is dysynchrony itself, sort of that same mechanism that we talk about with patients with a left bundle branch block, for instance. When you're actually watching on ultrasound, you can see that dysynchrony during those PVC beats. Tighter coupling, especially of PVC beats, it allows for electrical sort of resetting. The heart is ready electrically for that next beat, but not mechanically. So you don't actually get mechanical contraction with that PVC in a lot of folks. And so you end up with increased wall stress, essentially. You haven't ejected blood or very much blood, and that next following sinus beat is sort of overfilled. There's actually changes in the expression of sodium and potassium channels, and some changes in the spatial relationship from the endocardium to epicardium and calcium channels, as well as ryanodine receptors. So you actually get molecular remodeling over time as a consequence of this mechanical stress. And there's certainly, I think, sufficient data that in a large group of patients, this can be reversible. Let's see. So this is sort of an interesting study, and this graph gets shown a lot. So many of you have seen it, and if you haven't seen it, you'll see it again. So get familiar with it. It's a little bit funny to look at the first couple times that you see it. This is a study out of the Michigan group, and it was about 175 patients who were referred for PVC ablation. So pretty select group of folks. They were symptomatic, they'd come to someone's attention. And they basically just plotted PVC burden against ejection fraction and came up with these quadrants. So the most common quadrant for their PVC ablation cohort was in fact those with normal ejection fraction and a relatively low PVC burden. And their cutoff point for predicting the development or association with cardiomyopathy ended up being about 24% burden in a 24-hour period. So there were very few patients who had more than 25% PVCs but did not have a drop in their ejection fraction. And conversely, there are very few patients who had a lower EF but had fewer than 24% PVCs. So that's this orange quadrant here. But you can see it wasn't at all mutually exclusive. So for us to look a patient in the eye and say, oh, you only have 15% PVCs, you shouldn't develop a cardiomyopathy. I'm not sure we can really say that with such certainty. And some of those patients may in fact benefit from PVC elimination with either antiarrhythmic drugs or ablation. In this particular study, remember, they were being referred for PVC ablation. They went on to have their ablation, and they served as their own controls, if you will. So these are folks who had a mean ejection fraction of 35% before ablation. They underwent ablation with our sort of standard success, which I'll show in a second. And at the 6-month post-ablation mark, ejection fractions had improved by 20%, absolute improvement in ejection fraction. So really kind of a profound group. Wasn't randomized and wasn't pre-specified sort of what the treatment was going to be, in the sense that these were already folks referred for ablation, however. So then the next questions, and this group has done a lot of work, and it's really over 10 years old, but it still forms the basis of a lot of the recommendations that we make in terms of referring folks for ablation. So next question was really, if you have coronary artery disease and presumably have scar due to coronary artery disease, can we also improve your ejection fraction? And this really maybe isn't so surprising to folks in training now, but it was really back then. If you had coronary artery disease and had PVCs, it was felt to be that the ejection fraction decrease had nothing to do with the PVCs. It was because you had a myocardial infarction. But it turns out those folks are also susceptible and can be improved with ablation. So these are folks referred for ICD, and they were randomized actually to a PVC ablation and the ICD, or just the ICD alone. And you saw that a large number of folks moved into a non-ICD level ejection fraction, if you will. So here we are in the 38% range, mean ejection fraction moving up to 50%. So you can actually potentially decrease someone's sudden death risk as well, though the causation there is difficult. This is true also of non-ischemic cardiomyopathy patients. I tend to see this a lot less than ischemic cardiomyopathy patients in terms of the improvement, but we do see this. In their particular cohort, the PVCs mapped to this scar, and you can see this on MRI. This is an unusual scar pattern with sort of an anterior apical pattern. But again, improvement in ejection fraction, modest overall success, however, in the non-ischemic cardiomyopathy group. Can ablation of outflow tract tachycardia or outflow tract PVCs also improve ejection fraction? So if we slice it that way, the answer is also yes. So this is from Stavros Montagnakis when he was a fellow at Penn, a year behind me, a decade ago. Seems like a long time ago now. So these were folks referred for PVC ablation outflow tracts, and you can see the distribution here of the regions, epicardial being sort of a smaller number, but maybe larger than a general cohort of outflow tract PVCs because of the referral bias at Penn. RVOT still taking up the chunk of those patients, the cusps, including the right-left junction as a unique site, and the aortomitral continuity. And ejection fractions were improved from 34% pre to 47%. So I think that this is really a common theme, and that this should be a tool that's in our armamentarium and can have very important prognostic implications for patients. I love this study from Stavros because I perhaps overquote it when I'm talking to patients about PVC ablation, because he showed that even if we weren't perfect, which we frequently are not with PVC ablation, that there was a similar benefit for patients if you got their burden down to about less than 5%. So often this means that you didn't get rid of all of the morphologies in someone with coronary artery disease, let's say, or non-ischemic cardiomyopathy. But even folks where you maybe had partial success and are causing intermittent exit block from a region, if you can get the overall burden down, they see that improvement in ejection fraction. And I have to say, we often come back to this with particular patients where we just can't get full success. So if we treat the patients with PVC ablation, if we treat the patients with frequent PVCs, how does that go? What are the outcomes that you can expect? And we're going to be talking mostly about technique here today, but I think the background is really important for setting the expectations for the patient and also setting your expectations during a procedure. Because frankly, nobody ever died of PVCs in and of themselves. And so it's not the same thing as a ventricular tachycardia ablation. And keeping safety in mind with any ablation, but especially with PVC ablation, I think is really important. We're not going to go hog wild next to a coronary artery to get rid of a PVC that might be able to get treated in another way. So this is a reasonably sort of unique study. This is a study out of the Mayo Clinic database, and they looked at, I think, 5,000 patients who had the diagnosis of PVCs. They cross-referenced it with folks who had more than 1,000 PVCs in their Holter database, and then made sure everybody had echoes to look at. And then they looked retrospectively, there was about half the folks going for ablation and about half the folks, a little over half the folks getting antiarrhythmics, and they compared the two groups. So again, not a randomized trial. We really haven't had one of those, and I doubt we will, but a pretty large trial. And there didn't seem to be baseline differences in the patients that decided which treatment arm they went into. And this is a little bit busy of a slide here, but I'll walk you through it. So, except for it disappeared. There we go. I'll walk you through it. So this is PVC frequency on the y-axis, and the gray is baseline for each group, and the black is after treatment. So the first column here is beta blockers, and they go through the gambit of all of the antiarrhythmic drugs. And you can see that there's a decrease in PVC burden when you use antiarrhythmic drugs on average. And I don't think that's particularly surprising, but I think it's important to point out sort of the impact here. We have relatively small numbers when we get into sort of the quote unquote hardcore antiarrhythmics like mixilotine and flecainide, but still a really nice effect here. The last column here, which should be outlined here, is ablation. So this is right here, if you can see ablation, and they found that to be their most robust effect, with a 93% decrease in PVC burden on average, with most patients leading to complete success. So if we look at a large cohort here of PVC ablations, again, how good are we? What is your target in mind, and how are your colleagues doing before you go into this kind of procedure? This is a really nice study that Rakesh from Michigan as well, he collated folks from the original IBTCC cohort, so that's now expanded to about double the number of sites, and PVC ablation is still something that we're recording, so we should have more robust data sets going forward. But this is still 1,100 patients from 10 really world-renowned VT ablation sites. About half the patients, over half the patients were female, and that's kind of rare in ablation cohorts at all, so somewhat notable. They had a reasonably high PVC burden of 20%, and fairly preserved ejection fraction. I found this interesting. I thought the number would be lower. You can see the site of origin here, and this is in percentages here. So RV outflow tract is 45%, cusps end up being 15%. And epicardial 11%. I thought that was actually a relatively high number for an epicardial procedure, and then sort of a mixed bag on the others. Pat muscle is 5%, and again, you'll get a separate lecture on that. So what did they see? And this was divided by those regions. So overall is sort of this light purple that ends up right in the middle here, the fourth one down. But you can see for any site, our acute procedural success is reasonable, and it's best for RV outflow tract. And that becomes obvious when you look at the anatomy, and we'll go through that. So cusp comes in second, and then we start to sort of drop off. Pat muscle is a little bit more modest at 80% acute procedural success, and epicardial is somewhere down here in the 65. Long-term success, totally off drugs. There's an attrition rate here, and that's really important to recognize as well. So about 25% of patients who had acute success initially will then have recurrence and follow-up. So it's something that you need to be prepared for emotionally if you decide to be a PVC ablationist. So it looked good, and it looked good in the procedural holding area, and they come back at 3 months and it's back. And this is something that I hope that further ablation research can help us figure out why that might happen. But you can bounce that back up to that original success by reinitiating the antiarrhythmics. And I think this is something to keep sort of eyes wide open with the patient when you're going into that procedural discussion. But also recognizing that it's all site specific. So these are the common areas, like we talked about in his slide here. So RV and LV outflow tract, and that includes the cusps. The papillary muscles, both in the RV, meaning the RV papillary muscles themselves, as well as the moderator band, which seems to be more common. The Purkinje network itself, and then I put AV valvular, so this would be mitral and tricuspid valve. And for whatever reason, the mitral valve ends up being far more common. And then the LV coronary venous system. So we tend to see this a lot, but whether or not they're truly coming from the venous system and the muscular sheaths around the venous system really is of debate. Most of the time what we're doing is ablating from within that region, but still ablating the actual myocardium underneath it. Again, I find that true epicardial PVCs are rare. And then RV and LV apex itself is sort of an idiopathic region we do see from time to time. So switching gears to the actual PVCs and localization with EKG. I didn't get enough time to get all of my Diet Dr. Pepper drinking in the morning, so trying to stay awake. Nishant has my telephone number, so if I fall asleep, he'll nudge me. I know you guys went through this with Dr. Bradfield earlier in the week, and it really does bear repeating though. The outflow tracts of the heart until you start trying to ablate arrhythmias from them and putting catheters there, are honestly a complete mystery. I think that it's really helped in cardiology and in cardiology training that the structural heart teams are doing so many more interventions and so many more complex interventions, and that they are using somewhat disparate tools that seem to affect the anatomy and interact with the anatomy in such different ways. When I was a fellow, we were just starting to do TAVRs, we were just starting to do mitral clips and things, and the anatomy wasn't something that had been so critically important in this area. But for us, I really think electrophysiologists know the anatomy as well as any group within cardiology, even the imagers, because we're forced to recognize the physiology of the physical interactions between these regions. This is sort of a famous cartoon. I think Sam showed it when he did his anatomy lectures earlier in the COVID pandemic breakout here. But I think it bears repeating again. Basically, looking from anterior to posterior and from rightward extension to leftward extension from the perspective of the EKG lead of V1. So what's going to happen, and we'll get into more detailed EKG criteria, but V1 ends up really being what I call the lead that will embarrass you, basically. So if you don't pay attention to lead V1, if you don't pay attention to disparities in your pace map or disparities in the morphologies in V1 in the lab, you will end up with a long day. So it tells us a lot. If you're in the anterior RVOT, you are essentially right under lead V1. You are between the substernal space and the actual physical lead V1. So there's not going to be any deflection towards yourself. My cat. So there's no R wave here at the beginning of the QRS. Even moving into the posterior RVOT, you should get some R wave, and it tends to be very narrow. As you move more posterior into the cusps, and then certainly into the summit area, which we'll talk about, you start to get a broad R wave here. And then into the aorta mitral continuity, a much more broad R wave. And along the mitral annulus here, you get full positivity. There isn't really very much muscle posterior to the mitral annulus itself underneath V1 that's going to cause depolarization to be moving away from that lead. So why do we get PVCs from the outflow tracts? And most of the time when I ask this question, I just get a shrug, but there's actually a reasonable amount of interesting embryology studies that have come from this, and I think also speak to why some complex congenital heart disease patients have more XP and sometimes even VT from this area. And it really is that the right ventricular outflow tract and a small component of the LV outflow tract actually come from different tissue. So these are mouse embryos, and you can see that the right ventricle and outflow tracts, and in this case, the PA being the pharyngeal arch, not the pulmonary artery itself. But when these are stained for unique proteins that really are only expressed in this region, and then followed through to further development, you can see that these areas of muscle really uniquely contribute to these particular areas. When we get into more detail and stain with things like connexin 43, we again see differences in tissue characterization right around this pulmonic valve. So especially evident here in a fetal heart in the middle panel, you're seeing an absence of connexin 43 right around the valve and sort of the anterior RVOT. That seems to diminish as we get older. And clearly this isn't the entire story here, because we don't have a lot of kids where we're ablating outflow tract tachycardias. So there's clearly some maturing of the cardiac myocytes themselves, maturing of the autonomic system, maybe some acquiring of fibrosis in the area as well. So still some question marks there, but this is actually different tissue. And when you start to think about it that way, and then also think about the anatomic relationships, these aren't molds, right? They're not solid sheets of muscle uniformly lined up. in the outflow tracts. These are very complicated areas where heterogeneous tissue is coming together. And it helps you understand why you can get some funny results, or maybe not be completely, have completely straightforward mapping in terms of activation. So this is sort of the summary slide from that article, and you can also see there's differential expression in that region for EDIM sodium channels as well, the SCNA5A gene. And probably this leads to some of the other phenotypes that we see more severe than PVCs, like Brugada, and the more severe arrhythmias that we see with ARVC. Speaking of those, when should you be concerned about ARVC in particular when someone presents with frequent outflow tract tachycardias? And I would say really always when you're seeing these kinds of patients, it should cross your mind. Certainly folks that have multiple RV morphologies, so not just the outflow tract, but the body, complex ectopy, so that's non-sustained VT, especially shorter coupling intervals, couplets or triplets, and really any RV echo abnormality. I think that most of these folks with any of these risk factors, or certainly any abnormality on the resting 12-lead EKG, the sinus rhythm ECG, should undergo a cardiac MRI. And it's really debatable if everybody with outflow tract tachycardia deserves a cardiac MRI. And I have to say, I don't do a full RV voltage map in everybody, but I do if there's been any suggestion of abnormality. And I get an MRI in most folks, unless there's really a challenge in doing that for that individual patient. So here's an example of a patient who had frequent, what turned out to be RVO T-septal PVCs, but had some T-wave inversions that extended across the precordium. And so I did a full voltage map during that study, and it was actually really surprising. This is a patient who never had syncope, did not have any dilation yet on the echo, and at that time hadn't had an MRI. And although we had normal bipolar voltage, we had wildly abnormal unipolar voltage. And this patient ended up developing VT. This is why it's beneficial to be at the same center for a while. You get these kind of longer term stories. Was a patient of Jeannie's, and when I looked back at her endocardial voltage from that original procedure, really did foreshadow this epicardial abnormality. So I rarely put these full abstracts here, but I think this is really kind of one of those ones that deserves a look. So if you haven't spent time reading this article, came out last year in Heart Rhythm Society, how to use the 12-lead EKG to predict the site of origin of idiopathic VTs. In all honesty, if you follow me on Twitter, sometimes I get into Twitter wars about this. Like, the EKG is really important in mapping arrhythmias. It's really important in identifying potentially exits of ventricular tachycardias. But it's not the end-all be-all, and you really do have to put it together with the patient's unique anatomy and their unique conduction in the area. And I do find that sometimes the trainees especially get really rigid about these things. And I'll show you some examples from even this paper itself that don't always fit with the quote-unquote rules that we're talking about. So I would say learn these, and you would be expected to have this verbiage sort of as currency when you're talking with other electrophysiologists, but recognize that there's as many exceptions to the rules as there are rules, basically. So this article does this really nice job. There's sort of this beautiful diagram, which I've hidden part of here, I apologize. It's a posterior sort of tilted up view of the heart, and they're dividing it axially down between the right and left side of the heart. We've cut away the atria, and so you're looking through the AV valves here. We've got the outflow tracts up front, and they've done these cutaway views so you can see inside to the papillary muscles. So it's an ambitious paper really trying to cover all of these areas. Main sort of big heading discussions, or maybe main headings to get you going in one way or the other, is looking at whether or not these are superiorly directed PVCs or inferiorly directed. So it turns out there's not a lot of middle ground, statistically speaking, on this. You're either outflow tract or non-outflow tract, and those tend to be obviously very positive waves in lead 2 and 3. So taking that group first, the inferiorly directed PVCs, we're then going to look at lead 1, So not necessarily AVL, but lead one itself. And that really delineates, are you going to be on the left side or the right side of midline? That doesn't mean you're going to be in a left side or right sided structure. So it's really important to recognize that that right ventricular outflow tract crosses over midline, right? Your arms are crossing over when you're mimicking those outflow tracts. And the RVOT is actually markedly leftward of the LVOT of the aortic cusp, but not the entire thing. There is some overlap there. So as you move through, if you're positive in lead one, these are structures that are rightward of midline. You can have some positivity in lead one from the posterior RVOT, sort of posterior free wall. The right cusp itself is fairly lateral there. Parahistian, and then some tricuspid valve PVCs, which are fairly rare. Those will have a much more, a much later transition in the precordial leads. And then the negative ones here, anterior RVOT, left cusp, and AMC. And they have little hints here. It's worth going through and sort of memorizing these to some extent, but you should be doing that with this picture in mind and trying to work out in your head, why would that give you that transition? I think V1 can be a bit of a funny lead when you get back to the mitral annulus, but otherwise, the findings that you're seeing on EKG should make sense anatomically when you overlap that EKG axis onto it. Similarly, you can walk through this article, and I'll leave this for you guys for reference, the superiorly directed PVCs. They came up with this algorithm again. I find it to be a bit daunting, but it's a good reference for starting this conversation in your own head and working this through. One of the regions of the heart, or regions of the EKG that we really focus on, is the transition in the precordial leads. And what's meant by that is, where does a left bundle PVC move from negative or predominantly negative in V1 to predominantly positive, right? So again, remembering, thinking back in your mind to how those leads are placed on someone's chest. And I find this to be really important, and something that as electrophysiologists, we often have to get our hands dirty. So I'll go into the pre-procedural area and I'll see that someone's getting a nice EKG and V1 and V2 are in the mid-clavicular line for some reason in that patient, completely wide-spaced. Or V1 and V2 more commonly are placed too high, let's say in the second intercostal space and not the fourth intercostal space. This can also happen in your lab. Most of us have travelers coming in and out, and most of us make mistakes, it turns out, and that's true of your lab staff as well. So really taking a peek at that, scrutinizing that, especially if you have patterns that don't make sense. You can get big changes, and all of those criteria will be irrelevant if your precordial leads are moved around. This is also really important in obese patients and in female patients, where folks sometimes get squeamish about the female breast and don't put the EKGs in the correct place. So making sure that we're really lining them up with our usual landmarks. So with all of that EKG findings in mind, this is the table example that Furman and colleagues have in their paper. And I thought I would just go through a couple of them to highlight sort of how we're thinking. And again, something that you'll practice on the EKGs that you see coming from the lab. So if we look just at panel A and B here, column A and B here, these are clearly inferiorly directed PVCs. So we're somewhere in the outflow tracts. And my next move is to really focus on V1 and V2. So you see the difference between EKG A and EKG B is honestly fairly subtle, right? But they're hoping that we'll see PVC A as a posterior RVOT PVC. So that's going to be slight positivity in lead one, slight positivity in lead one. And really very little to no R wave, slight positivity in lead one, limb lead one, and some very little R wave in V1, the precordial lead V1. Whereas when we move more posterior to the right coronary cusp, you start to get more positivity here. And it's actually fairly wide in V2. And if you draw a line up to V1, you'll see that there is actually a fairly broad R wave there. It's just low amplitude. That's another thing to say. So just like your delta wave algorithms, we really should be drawing those vertical lines, trying to look at these EKGs. These are rhythm strip EKGs, right? Not just the standard 12 lead EKGs, so that we can really compare where the onset is in neighboring leads. So here's another example.